All right. We got anybody waiting, Lisa, or we got everyone who was trying to get in is in right now?
I'm going to add them as we go.
Okay. All right. I want to make sure we have enough time for questions here. Dr. Flores, you okay with getting started now?
Yes, go ahead, because the introductions will take a few minutes too. So
that's right. That's right. Okay. Well, for those of you who are here with us tonight, welcome and thank you for joining us in this series. As you know, we have a monthly series of discussions regarding various approaches for healthcare expansion and equitable coverage for all. And we are very excited for today. We have John Baackes with us. I'll tell you a little bit about him here, and then I will hand it over. John Baackes is Chief Executive Officer for LA Care Health Plan. That's the nation's largest publicly operated health plan, serving almost 2.5 million members in Los Angeles County. LA Care is dedicated to providing access to quality and affordable healthcare for Los Angeles County residents through a variety of healthcare coverage programs, including Medicaid, LA Care Covered, California Health Benefit Exchange, the LA Care Cal MediConnect Plan, and PASC SEIU Home Care Workers Healthcare Plan. Mr. Baackes works collaboratively with the Board of Governors to set the organization's strategic vision and ensure its successful implementation. He also oversees the day-to-day operations while guiding LA Care through the ever-evolving healthcare landscape. Additionally, he is responsible for maintaining the integrity, quality, and accountability of the health services LA Care provides to its members. Mr. Baackes brings more than 40 years of healthcare experience. Before joining LA Care, he served as president of Philadelphia-based AmeriHealth Caritas VIP plans, where he oversaw the Medicare Advantage business unit. Prior to that position, Mr. Baackes was CEO of Senior Whole Health in Cambridge, Massachusetts, a voluntary healthcare plan of more than 10,000 low-income seniors in Massachusetts, as well as New York. He currently serves on the boards of America's Health Insurance Plans, California Association of Health Plans, Local Health Plans of California, Project Angel Food, Urban Voices Project, and Charles Drew University. Throughout his career, Mr. Baackes has served in a number of executive leadership roles across the healthcare industry, including Senior Vice President for Group Health Incorporated in Albany, New York, President of Kaiser Permanente's Northeast Division in Latham, New York, and CEO of Community Health Plan, also in Latham. Mr. Baackes holds a bachelor's degree from Southern Illinois University, Carbondale, and is native of Evanston, Illinois. Great pleasure to have you with us, Mr. Baackes. Thank you for joining us, and we look forward to hearing a little bit about your expertise on the subject. So thank you. With that, I'll turn it over to you.
And John, if you don't mind, I just have a little housekeeping to do. Two things. Sure. One, none of the speakers have any financial disclosures to make or any conflicts. And secondly, we're recording this session for future view. And then thirdly, feel free to put in your questions in the chat function so that we can include them in the Q&A session. So thank you again. John, it's all yours.
Thank you.
Well, thank you thank you very much, Dr. Dean, and thank you very much, Dr. Flores, for inviting me to be with you guys tonight. I'm very interested in talking about the public option because I think it's the most least understood option that we have in front of us as a nation to address the complexity of our healthcare system, the costs, and the problem of universal access. I don't think if you ask the first 5 people on the street what a public option is, that any of them would give you the same answer, because I don't think it's well understood what a public option is. So for definitional purposes, I'm going to use the public option as it was described in the version of the Affordable Care Act that passed the House of Representatives in 2010 and then was sent over to the Senate. As you know, the bill passed the House, and when it got to the Senate, Senator Joseph Lieberman of Connecticut, which is, as you know, the home to many large national insurance companies, said, if the public option is in this bill, I'll filibuster it to death. So in the House version, they described a public option, and they did it as follows. The idea was to create a public entity in each state that would compete in the individual market against commercial insurance companies. And the idea was that the public entity, which would be essentially a not-for-profit, but with total transparency, would be able to compete effectively with the commercial insurance companies because it would have lower margins, it would have no shareholders to reward, and it would reduce prices over time. And as I said, Senator Lieberman said, essentially over my dead body. So it was dropped in the Senate version, and the House conceded, and the bill that went to be signed by President Obama did not include a public option. So if that's the definition we have, a public entity that competes against commercial insurers, we've made the supposition here at LA Care that we are, in fact, the largest operating public option in the United States. Now, how did we get to that conclusion? Well, if you are familiar, and I know many of you are familiar with the origins of LA Care and the other 15 plans in California that are considered public entities or local initiative health plans, we were formed by an act of the state legislature in the 1990s when the idea of bringing managed care to the Medicaid population, or Medi-Cal, was first floated. And the concern was that the commercial insurance companies, with their need for margin and rewarding shareholders, or even if they were not for profit, meeting what their idea of adequate operating income was, that they would be fickle about the rates in Medicaid because they could fluctuate up and down, and that they would drop out. So the state legislature said that since the counties contribute to the cost of Medicaid in California, we will allow the counties to create local initiative health plans that can operate in those counties, and they set up some guidelines. So here in Los Angeles, the Los Angeles County Board of Supervisors adopted an ordinance taking advantage of this law that created a public entity health plan, which is now LA Care. In the model that they chose from the state, it was a two-plan model. So we compete against HealthNet, the commercial plan that is available to Medicaid beneficiaries here in the county. And I will say I use Medicaid instead of Medi-Cal because in the 40 plus years I spent before I got to California, it was called Medicaid in every other state. California, of course, has to call it something different. So anyway, because we were set up by state law and county ordinance, we meet the definition of a public entity. As a result, we're subjected to the Brown Act, which requires that all public entities are open to the public at board meetings, that we are transparent, that we have no shareholders, and we are organized as our 15 other plans in the state. So because we meet the definition of a public entity, of the 16 entities here in the state, we are the only one that participates in the individual market exchange created under the Affordable Care Act. And as you know, California was one of the states that set up their own exchange, Covered California. So LA Care competes in the Covered California exchange. And here in Los Angeles County, there are 2 rating regions. We're in both of them. And in one, we have 4 competitors, and in the other one, we have 5 competitors. And the history of our participation in Covered California here in Los Angeles, I think is instructive because it meets the requirements, or not the requirements, it meets the aspirations that were in the original House of Representatives version of the Affordable Care Act. So we compete against 5 commercial plans, and they include Kaiser, Anthem, Oscar, Blue Shield, Promise, and depending on which rating region we're in, I think we're up against Molina. But what has happened in the first 3 years, beginning in 2014, this was new business for LA Care, and we didn't have a history in it. So it took us about 3 years to get our sea legs. But by the time we got to the 4th year, we had the lowest priced options in the exchange, and our enrollment skyrocketed because the individual marketplace exchange is a highly price sensitive market. You're talking about people who are buying insurance directly without the benefit of an employer or any group coverage. And so they're going to be very careful about what the premiums are, what the co-payments are, and whether or not their doctor or favorite hospital is in the network or not. So when we got to the 4th year, our enrollment jumped by 56,000 members. We enjoyed the same price advantage in the 5th year. By the time we got to the 6th year, the commercial plans were going, well, what the heck is LA Care doing? We never thought of them as a competitor. And they sharpened their pencils and reduced their pricing so that we were in 4th position in that 6th year. In the 6th year. We still grew, but not by as much as we had. We went back and sharpened our pencils, and in the 7th year, we again had the price leading position, and that is where we are now. And we had another increase in enrollment. So what happened in the 4th year, the 5th year, the 6th year, and the 7th year is we all reduced our premiums. So the idea of the public option as a public entity without shareholders, without requirements to meet a commercial insurer's sense that they have to have deep reserves, we were able to reduce the pricing. Now, I do want to add that we have made money on this product. We didn't in the first 3 years, but once we sort of figured out how to do it, it is a net contributor to the bottom line. It stands on its own. We do not in LA Care cross-subsidize any of our lines of business. So we have a Medicaid line of business, or Medi-Cal. We have a commercial line of business, which includes this product and the PASC SEIU in-home support service workers. And then we have a Medicare product. So this product has turned out to be a very good investment on the part of LA Care in terms of serving the community. Now, one of the reasons LA Care got into the individual market exchange is that because our Medi-Cal members, when they earn more than the ceiling of 138% of the federal poverty level, are no longer eligible for Medicare. And they may fall out of Medicaid, because their earnings go up. They get a job, something like that, but they may not get health insurance with that job. So they can then go into the exchange, and with the exchange, they are eligible for subsidies. So 42% of the people we have in our covered California product pay no premium. They get a subsidy that totally covers it. They're still subject to co-payments and deductibles, but those are manageable. So, excuse me. So over the course of the years that we've had participation in covered California, we've had over 40,000 members flow back and forth between covered California coverage and Medi-Cal coverage. So we make the statement that we're the only functioning public option in the United States, because I haven't found another plan organized like us that's considered a public entity that is participating in any of the ACA individual market exchanges. Now, with that said, there's some things that you should know about our participation in Covered California that seem to run contrary to what people think a public option is. First of all, we had to apply and compete against the other commercial plans. We got no special favors. We had to make all the same requirements they did to be called a qualified health plan. Secondly, we had to go out and build a network of providers to participate in this product. Now, we had a huge network because of our Medicaid program, Medi-Cal, and we went to all of those physicians and hospitals and said, we're going to get an individual market exchange. Would you like to participate? And they did. Now, there was no mandate on what we pay them. So we had to compete in the marketplace for their participation by offering competitive rates. And most of our rates in our Covered California product, excuse me, are Medicare up to 120% of Medicare. Secondly, or thirdly, there are no subsidies other than the subsidies the members are eligible for based on their individual income. So in other words, we compete on the same even playing field with the commercial plans that are part of the individual market exchange, which I think is an important thing to remember when we're talking about the public option. So that's our claim to being part of Covered California and being a public option. Now, we have talked to the other public plans in California about why haven't you joined us on this? Because we think it's turned out to be a pretty big deal. Well, probably the largest reason is that the size of Los Angeles County. 10 million people, it's the largest county in the country. It's bigger than 43 states. And there was enough of a marketplace in the individual market that we could enroll enough people to make it profitable. Remember that in the state of California, there are probably about 1.8 million people now enrolled in Covered California in the individual market exchange, yet we have 14.5 million people in Medicaid. So the other plans who are in smaller markets than we are just did not feel that if the individual market was about 10% of the size of the Medicaid market, that it made sense for them to invest the money to participate in it. Now, I do have it on good authority that the next two largest plans are planning to become part of Covered California's offerings in the next 2 years, partly because they've seen what we've been able to do with it and the ability to have this as an option for our members to move back and forth between Medicaid coverage and Covered California coverage, I think has been instructive to them to say, why can't we offer that same thing to our members? Now, part of the problem, if I could move on to another aspect, is what other people think a public option is. LA Care is part of America's Health Insurance Plans, which is the large national trade association for insurance plans, and I am on the board of directors. And I have to tell you, I'm very disappointed in the NAHIP's position on the public option. And I think they're doing a huge disservice to the public in how they position their support or lack of support for the public option. AHIP joined a coalition of 85 trade associations that created the Partnership for America's Healthcare Future. And they did this in anticipation of, excuse me, of a new administration coming in 2021 that would look to expand the Affordable Care Act. And the position of the Partnership for America's Healthcare Future is that they are opposed to a one-size government solution for healthcare. And so they are opposed to a single payer Medicare for all, and a public option. So I have endeared myself to the rest of my board members by challenging this assertion at a board meeting by saying a public option is not a one-size government solution. First of all, it's got the word option in it, which means it's a choice. No one has to join it, which would be the case with a single payer or Medicare for all. It's an option, so it has to be attractive and competitive for people to join it, and it means that there's something else for them to choose from. So in spite of them continuing to support it, I still go to the board meetings just kind of to be a pain in their ass, frankly, because somebody needs to point out the hypocrisy of calling a public option a one-size-fits-all government solution. So that brings us to where are we and what can a public option in a broader application do? And I know you've heard from Steve Shortell at a previous meeting about the work he and his colleague are doing about looking at the public option. So if we go back and look at the model that we have here in Los Angeles County, we're saying that a public option has to be based on a public entity that carries the license and is the entity responsible for the work of the health plan. Now, 3 other states in the last 2 years have adopted what are labeled public options: Washington, Colorado, and Nevada. Now, in the case of all 3, there is no entity that's a public option. They're calling a program, which is basically their individual market exchange, the public option, and they're awarding all the plans that participate are private health insurance plans, for profit or not for profit, but none that have the public entity label on it. And they're calling that the public option because people have a choice within that exchange. Now, one of the states, I think it's Washington, for some of the plans, they can't, they have payment limits on how much the plans can offer the providers. But those are all, in all 3 cases, they're ceilings. They can't go over a certain amount. I believe in Washington, it's 160% of Medicare. Colorado, it's 155% of Medicare, and similar rule in Nevada. So that allows the private insurer in those states to be as competitive as they think they can be in attracting providers to participate in the plan. But by setting those ceilings, they also automatically, I think the providers go, well, if that's a ceiling, I want the ceiling. So they're all done with the idea that this should be resulting in a lower price option for the potential members. Like the individual market exchange in California, the Colorado, Washington, and Nevada plans will have similar benefits in the individual market. So all the carriers cannot distinguish themselves on benefit design because they all have to have the same. They can only distinguish themselves on price, network, or customer service, which of course is the same case we have here in Los Angeles County. The benefits are the same across all the options, and the differences are in the price, our network, and whatever the public perceives as our brand on customer service. So that is my take on the public option as it exists today, where it does exist, and where it could go. I would hope that in California, that the other Medicaid managed care plans situated like LA Care would join and be an option available in those counties where they operate, and that in those other counties where there is no public entity, the state encourage the creation of those, because I do believe it does provide a viable option to a commercial plan. And it's the rural areas, it can be done through one plan operating in multiple counties. Partnership Health Plan, which is one of our other public plans, operates in 15 counties in Northern California. Now, people have asked me, well, how is this going to reduce costs, and what would really happen, and can we ever, are we all going to be wind up being reversed at the mean, and the mean is Medicare or Medicaid? I can tell you personally that the options that people be allowed to opt into Medicaid, I think, is a terrible idea. Some states have discussed where any citizen in the state could sign up for Medicaid. I think pay a premium to Medicaid to participate. But the problem is that Medicaid is seriously underfunded. And here in California, Medicaid is 47th in the country in terms of its level of reimbursement. That is intolerable. And we really we cannot allow that to be the mean by which we pay all providers. I think that problem with Medicaid has led to what the situation we have today. We have huge inequities in health outcomes for people on Medicaid. And I think it's directly related to the fact that we don't provide enough compensation to incent providers to see Medicaid beneficiaries, or more importantly, to set up practices or build hospitals in communities where there are a large concentration of Medicaid members. So as you know, most of you are aware, 1/3 of the population of the state of California is on Medicaid. So it's not a cohort that can be ignored, but it is a cohort that is not funded properly. And I do think that we need to be focused on correcting that in the long run. Do I think paying Medicaid doctors more or Medicaid hospitals more will lead to a reduction in the cost of commercial insurance? Because I'm sure you're all aware that commercial insurance has been subsidizing many providers who accept Medicaid but need the commercial insurers' higher reimbursement to balance the books. So in a moment, I'll go to questions, but I'll end with one idea. I think one opportunity we've never explored seriously in the United States is getting employers out of the health insurance business. As most of you are aware, that was a historic accident in World War II, where wage and price guidelines were put in effect, but they granted an exemption that health insurance, if the employers provided health insurance, that would not be subject to the wage and price guidelines. So employer-based health insurance took off, unions grabbed onto the idea, and as we rolled out of the war into the 50s, group health insurance grew at a rapid pace. So if we were to go back and change the original fundamental there, that the cost of the health benefits is a deductible for the employer, and eliminated the employer as part of the equation, then we would say to individual employees, you go buy your own health insurance. You buy your own car insurance, you buy your own house insurance. And my contention is that most people are savvy consumers about that and know way more about their car insurance and their home insurance than they do about their health insurance. Because in an employer-based setting, it's picked by somebody else. There may be options offered to you, but people generally go for the lower priced option. So if we return the idea of buying insurance to the individual employees, I think they would be consumer savvy, as we see in the California Individual Market Exchange covered California. And that pressure would do more on the private insurers who would participate to bring down costs. And it would also create revenue for the government, because they would now be able to tax the income coming to the employer would not be able to deduct the cost of health insurance as a business expense anymore. And the incomes of the individuals would be create additional income. So I'm sure that's an idea that is probably the subject of another meeting sometime. But Hector and Dr. Deen, at this point, I'd be happy to answer any questions. I know you sent me some in advance, so I'll let you guide me on how you want to handle that.
Thank you very much, John. We appreciate you taking the time, and for our audience, it's important to know you just came from a long trip and you still graciously made it to this meeting, so we appreciate it.
Thank you.
And now that we know that you're a lifetime member of PITA, P-I-T-A, at least as AHIP sees you, right? I have a question for you. A couple questions that were pre-submitted and then a couple that came in through the chat. One is that you've explained, I think, how a public option would make healthcare more affordable by bringing in competition, and you cited some really good data from LA Care's experience. But we've learned recently from Kaiser Permanente's agreement with the state that they subsidize Medi-Cal to the tune of $2 billion a year, $2,000 per person per year. LA Care and the other Medi-Cal health plans do the same. You do that through community benefit grants, and you do that through elevating the safety net and other kinds of initiatives for hospitals. So how can we mobilize quickly to get some equal pay for equal work in Medi-Cal? And where can the public option help in that advocacy?
That's a great question. So, the losses that Kaiser advertises, and frankly, Kaiser is a planned partner of LA Care, as most of you know. They take care of about 10% of our members. We don't have a line of sight into their total cost structure. We only see the costs they assign to the Medicaid members. So we don't really know if that's what it costs them or not to serve those members. Obviously, Kaiser is a very expensive closed system to operate, and it drives the pricing of their commercial business. And they generated an $8 billion surplus last year, and that included their loss on the Medicaid business. So I think what we have to make sure that Kaiser is not reimbursed at their costs. They have to be reimbursed at the same amount that the safety net providers are reimbursed at, because if we do that, we're creating an unlevel playing field by giving Kaiser more resources than we're giving the safety net providers, who have no big surplus from a commercial line of business to fall back on. So what we're doing right now is lobbying the state legislature, who has to approve the Kaiser deal, to make sure that Kaiser does not get anything more than what any of the other Medicaid providers get, based on the acuity of the members they take care of. So I think part of the effort, we should be lobbying the state, and this should be our trade association of local plans, the California Primary Care Association, CMA, CHA should be lobbying for equity in payment for Medicaid providers. Now, some Medicaid providers like FQs and the public clinics get additional funding over and above what we pay them. But, we couldn't take care of our Medicaid population if we relied only on those core safety net providers, the publics and the FQs. They maybe could take care of about a third of our 2.5 million people. We need the rest of you. We need the community-based providers who do not get any extra income. They don't get grants, or they don't get QAF payments, or they don't get intergovernmental transfers. And without the rest of you, the system would collapse. So I think we need to be educating the state about that. They don't get it, or the legislators don't get it. But the state is sitting on another humongous surplus, $68 million. Not a penny of that has been devoted to equalizing or improving the payments to Medicaid providers. And as I say, I think that's the largest contributor to the fact that we have inequities in health outcomes among people of color, most of whom are covered by Medicaid.
That's a great point, John. I attended a virtual meeting at the Gear Center at USC. They invited Dr. Jose Figueroa from Harvard School of Public Health. And basically he says that low Medicaid payments are a reflection of structural racism, because most of the people covered in Medicaid, and certainly here in California, are underserved minorities. So that's another perspective that I thought was really helpful in making the case for the improved payment.
Well, and Dr. Lane Batchelor makes the same case, and I've joined her club and her phrase of equity in payment for Medicaid, because I think that is really, really important.
Dr. Flores, I think we might have lost you. It's breaking up a little bit.
Oh, sorry about that. I was just referring to you. I think you had some questions as well around Medicare reimbursement.
Yes, thank you. So it was specifically about this, this discussion that we have heard quite a bit about Medicaid and Medi-Cal reimbursement for us here in California, that a lot of the barriers to care are specifically that the reimbursement rates are so low that most providers that I know are not able to see Medi-Cal patients or Medicaid patients outpatient. And of course, the problem is that these patients get their care driven to the emergency room, and are not able to follow up as an outpatient after those hospitalizations or those ER visits. But another issue is Medicare reimbursement, which has been declining over the years. Looking back at 1981 reimbursement rates, we've seen multiple cuts over the years to reimbursement. And I think that's something that needs to be addressed also. And I wonder what your thoughts are on that, on general Medicare rates for providers, whereas other expenses in healthcare seem to be going up as far as hospitals, procedures, imaging, but reimbursement to providers seems to be lagging.
Well, interestingly enough, CMS announced that for Medicare Advantage plans, they got an 8.5% rate increase for next year, which shocked most of us. So I think Medicare is becoming bifurcated in a way between fee-for-service and the Medicare Advantage plans. So I would think that reimbursement may be beginning to shift more to a more lucrative arrangement through the Medicare Advantage plans and straight fee-for-service Medicare. Now, part of the reason is that the Medicare Advantage plans are looking for value-based payments. So they're looking for a way to reimburse based on quality or some statistical measure, whereas fee-for-service Medicaid or Medicare just grinds out a payment and doesn't look at any of that. So I'm not saying that Medicare Advantage is necessarily the answer to solving Medicare's financial problems, but I think what Medicare Advantage does is it bundles the payments across the spectrum. And if you can save on hospital costs, then that gives you more money that you can pay the providers. Now, I can tell you at LA Care, because we're a public entity, that's exactly what we would do, particularly for, and by the way, we consider any doctor who participates with us in the Medicaid program as a safety net provider. You don't need those labels of federally qualified or a public clinic. So I think we have an obligation to pay top dollar as much as we can, both in Medicaid and in Medicare, to the providers in our system. So I guess my answer, Dr. Deen, is that organizing and bundling the payments is a way that we can begin to get more dollars directed to the right place. And I think that needs to be looked at.
John, for sharing that. I'm kind of following up on an earlier comment you made about local initiatives, especially LA Care being kind of uniquely qualified for public option. What do you see as potential barriers to having the state adopt local initiatives as public options, getting them into covered California and individual market as you outlined? or would they default to a statewide that could be existential for the local initiatives?
Yeah, I think for those counties that did not exercise creating a local initiative plan, there's no reason the state can't create a local initiative to cover the balance of the state. I mean, the 16 plans that are here, we have history, we have talent, we have all kinds of things that will continue to apply. And if we have to start from scratch, at this point, I think the state could, through enabling legislation, create a local initiative that covers the rest of the state, which are mostly rural counties. So I think that would be a way to do it. And you don't need an individual plan in each county. We have that in mental health for Medicaid, and it's a nightmare. Every county has its own Department of Mental Health, which operates as the mental health plan for people with serious mental illness. And it's nonsense to have plans that small as like Mono County and those places. So I think we could be doing it that way. I think would be an improvement, Hector.
Right. And kind of leading back to the role that local initiatives play, each of the local initiatives has plan partners. And would a public option potentially threaten or disrupt those relationships?
Well, no, we have plan partners, but only in Medicaid. The plan partners do not come with us in any of our other product lines. In fact, we're competitors in the other product lines, and we're getting along fine. In fact, our relationship with Kaiser, in spite of all the things they do, has been very harmonious, as has our relationship with Anthem and Blue Shield Promise. And more, we try to act in unison. As many of you know, we do a report card on the performance of our contracted medical groups, and all three plans participate in it. Kaiser participates as a medical group, and then each of the medical groups that our plan partners have that we don't have, we cover in that. And what we've been able to do with that report card, which looks at quality, customer satisfaction, key utilization metrics, and the timely submission of encounter data, is that over the years we've been doing it, the range of scores has gone up. And as a result, our standing with the National Committee of Quality Assurance has gone up. So I think that shows that we can, if we combine data and use it, we can effectively incent our participating providers to look at where they can spend their resources. Now, frankly, I'll tell you probably the biggest thing that's helped the scores goes up is people are submitting more encounter data, which wasn't a big lift. You just have to put the stuff in the envelope or hit send and get it over to us. But I think that has been a really kind of important thing. Now, the other thing I would want to add here, just so people know, we have another structural deficiency in California around how the plans get paid. So the state of California does something called county-wide averaging. So what that means is in a place like Los Angeles County, they figure out what our rate would be based on the risk of our members and our experience and our costs. They do the same thing for HealthNet. Then they compare the two rates. And 75% of what we're paid is based on averaging those two rates. And 25% is based on our own. Because LA Care does pay more, we are a loser on countywide averaging. And last year, or the current fiscal year we're in, $216 million that would have come to LA Care based on our risk profile and our costs was sent over to HealthNet. So our higher costs are kicking us in the ass on rates, and then we hand $216 million to HealthNet, which is a for-profit entity whose profits go out of state and do not accrue to the benefit of Californians. The state doesn't save a nickel in this countywide averaging. And the point I have asked the state multiple times is, what is the policy objective of this sort of countywide averaging? And the answer is to incent efficiency. And my response is the only thing you're incenting is for us to pay less to our providers. And we will not do that. Because again, we don't have shareholders to worry about. We can operate on a 2% margin. And out of that 2%, we build reserves. And those fund things like elevating the safety net. So if we had the additional $216 million, we'd still try to operate at a 2% margin, and that would be funding available to pay the providers. So I think this is an unconscionable policy, yet we have not been able to get the administration to take it seriously. They have a work group right now that's working on it, but we're saying, why aren't we paid for quality? And if we look at quality as measured by HEDIS and NCQA, the state looks at that when they're calculating what's known as the default assignment. So I'm getting into the weeds a little bit here, but follow me along. When a beneficiary goes to apply for Medicaid in LA County, they get a long form and they have to check off a box. They want to be in LA Care or they want to be in Health Net. Believe it or not, 40% of the people don't check off a box. So the state then has an algorithm by which they auto-assign them to one of the two plans, and it's based on quality scores. Since our quality scores are higher, we get 67% of the default assignment, and Health Net gets 33%. Yet we're handing $216 million over to Health Net because they pay providers less. I think that's an unconscionable public policy.
It really speaks to the complexity of Medi-Cal. You know, I teach our residents that Medi-Cal is the most politically intense product we have in healthcare, far more than Medicare, far more than commercial. And you know, you're speaking to those issues. Many of the sort of the counters from the commercial plans like Health Net or Anthem and other communities, et cetera, is that local initiatives have favored nation status, so they get some benefits, they get additional payments for that favored nation status. Do you see that as being accurate? And do you see opportunities with the waivers, the Medi-Cal waivers?
We don't get a nickel more than Health Net does. We don't get any special favors that way at all. So let's dispel that rumor. We have to go out and negotiate to get doctors in our network. No one's mandated into it. We constantly are negotiating with you guys, with the hospitals, and it's really tough. So that's a fallacy. We do not get any favored nation status. So now that I got so diverted by that, I forgot the rest of your question.
And it was, do you see some hope in terms of, obviously there's advocacy to correct the inequities that you described, but do you see some hope in kind of mitigating the impact through the waivers like CalAIM and resources that could come?
Sure. So CalAIM is a very interesting addition and benefits, but let me, and I'm sorry if I'm kind of getting on a soapbox, but this is another one that drives me nuts. So CalAIM, the main focus of CalAIM is beginning to integrate social services that our members are entitled to into the care plans, particularly for the most vulnerable people. For instance, if we know that Mrs. Smith has a food issue in her diet, then maybe we should get that person on CalFresh. But right now she has to go do that herself. We should be able to do that for her because we see the need. We should get the solution and marry it for her. So we're beginning to inch towards that with CalAIM. But within CalAIM, there's something that they're calling community supports. And what they want is to begin to use Medicaid dollars to pay for non-healthcare items on the theory that paying for those will reduce healthcare expenses. For instance, the patient suffers from asthma, will buy an air conditioner for their wherever they live to help them breathing. And that should cut down on emergency room visits and maybe readmissions after hospitalization. Medically tailored meals is another one. We've been paying for those for years out of our unassigned reserves. Now we can order medically tailored meals and use Medicaid dollars. But the idea is every dollar that you spend on a community support should be paid for by a reduction in a Medicaid dollar expense that went to a doctor or a hospital or a pharmacy or any other healthcare provider. There are 14 community supports. To me, medically tailored meals is the only one that's going to pay for itself. But the others, like supportive housing, recuperative care, sobering centers, for those places, remember, we're trying to save a discounted dollar, a discounted Medicaid dollar, but we're going to have to pay retail for those community supports. In the end, it will not balance. We will not be able to save precious Medicaid dollars, which are already discounted terribly, by spending retail for these other community services. So we're all in. We're going to add all the community supports over 2 years. But I think in the end, the state is not going to find that it has reduced Medicaid expenses. But at the same time, people like me are arguing, well, you should put more money into Medicaid, not less.
Okay, thank you. Could you describe what LA Care has done to address a workforce shortage and specialty maldistribution, and maybe relate that to what public option could do, maybe far more?
Sure. Well, as you know, I said they build into our Medicaid reimbursement the ability for us to make a 2% margin. Now it's up to us to actually make that happen. It's not guaranteed. But it has allowed us to build up a reserve over the years. And 5 years ago, I went to our board and asked if we could set aside 5% of our unassigned reserves for workforce development. And that has led to a 4-part program. One part that I think is the important one here to your question, Hector, is that we know that small practices, FQs, when they go to bring doctors into the practice to replace someone who's retiring or meet a demand, they have to compete against Kaiser and the academic medical centers, and they can't. They don't have the resources. So we have offered grants of $125,000 to practices or clinics that would bring a new primary care doctor or psychiatrist into the county's safety net. And it has to be new. It can't go hire the guy across the street that's in another safety net program. It has to be new. And they can use that $125,000 any way they wish. We know that most of the doctors coming in will have significant medical school debt. And if the doctor agrees to stay for 3 years, we'll retire $180,000 of that debt, which at the time was the average medical school debt. Some are a lot higher, I know. So that has given those practices and clinics a $305,000 package that they can use to compete with the other options available to doctors coming into LA County. And I'm pleased to say, since we gave the first grant out in 2018, that we have funded 142 doctors that are here today that weren't here back then. And most of that has been in places like the Antelope Valley, South LA, Eastern San Gabriel Valley, which is where our members are in deep concentration. The 3 other elements of the program, one is we fund 14 primary care residency slots in 5 programs across the county. And we also give out medical school scholarships. We do 8 every year, 4 to Charles Drew, 4 to Geffen UCLA. And we say to the schools, you know the students walking in the door better than we do. You pick the winners. And we would like them to pick students who express an interest in coming back and working in the safety net. And we're hoping that the fully paid scholarship relieves them the medical school debt that might have otherwise driven them into a specialty service, but that they come back in primary care. So we've given out 32 of those. We'll announce 8 more next month. And our first cohort that we sponsor will be graduating in June. And I can't wait to go to graduation and see them. And then the last element of the program is that I'm sure you're all familiar with the in-home support services program, which is outside our capitation or our benefit plan, but it's in 8 counties in California where if a Medicaid beneficiary can demonstrate deficiencies in activities of daily living, they get to pick somebody to be their caregiver who automatically gets SEIU membership and health insurance provided by LA Care. So 90% of the folks that are picked are family members, and that doesn't mean they know anything. So they become really babysitters with benefits. So we went to SEIU and said, look, we should be doing something to make these caregivers more valuable members of the care management team. So they created a 10-week training program, which is done in the caregiver's language of choice, English, Spanish, Russian, various Chinese dialects. And they are taught what's managed care. They're taught basic observation skills. They're taught how to take care of themselves, because we all know that caregiver burnout, even if you're getting paid, is a leading contributor to nursing home admissions. So we have trained 4,400 of these people. I think it's been a great program. They love it. And I believe we really saved lives during COVID because these trained caregivers were able to keep their clients safe at home. And as we all know, being in nursing homes at the beginning of COVID was a death sentence.
Great, thank you, John. Question from the chat is, how would a public option further the efforts from Governor Newsom's Healthy California for All Commission, trying to achieve universal coverage, or would it make a difference?
Well, we haven't heard the report from the Healthy California for All Commission. So I'm hoping that they included expansion of the public option as a first step. So the public option, as it's exercised in California, does include public entities in the mix with commercial insurers. And I think that begins to change the dynamic where it's not so much a case of can I get away with a larger profit by how I price or how I price the product or how I pay for the providers, but I think it becomes how can I compete in a way where I get the most efficient price, and I think that would be a first step.
Great, and kind of a sort of a prequel to that question is, before we get to that universal coverage, the governor has plans to implement the Office of Healthcare Affordability.
Yeah.
How would the public option enhance what the governor tries to do through that office?
Well, the Office of Healthcare Affordability is going to ask for tons of data, and we collect tons of data, and I think we can show that the outcomes for our members are just as good or better. I mean, I would again go to our quality scores as a public option compared to the commercial plan and say that we can show that you can kind of remove the profit motive from the pricing and accessibility to make access more universal.
Well, thank you, John. As usual, great conversation with you, and time flies. We're actually at the end of the hour.
Sure
want to
does.
thank you for a wonderful presentation. You made a public option very understandable and
Well,
you know, a real possibility. So Dr. Deen, we'll have you give some wrap-up comments. I do want to remind the participants, Lisa Lee will email you an evaluation form, and if you kindly fill it out, it helps us in planning our programs, but also we'll give you the CME credit. So thank you again,
Hector,
John.
could I just say one thing in closing?
Sure.
Thank you for this opportunity to speak with you. I think that LACMA is a great partner for what we're trying to do at LA Care. And I know you represent some of those, some of those providers who are in the areas serving our members. And we really would like to be your advocate in Sacramento and making sure we get the best compensation for you possible. So thank you for this opportunity.
Thank you. Thank you very much.
Thank you. Thank you, John. Great presentation. And thank you, everybody, for your time and your participation. Hope to see everybody at the next session. next month. Thank you.
Thank you, everybody. Take care, John. Get some rest.
Very much, John. It was really a great presentation you gave. One of the best I've heard for LA Care. And I'm looking forward to speaking with you in the future. Take down my name. Well, I've met you before. We're going to talk again. I have a lot of things to say to you.
All right. I'll look forward to it.
And then take
Thanks,
the rest of
Ralph.
the day off.
Bye.